Welcome, everyone. I'm so pleased that you could join us this evening. I am truly looking forward to Dr. Frank's presentation. Tonight, we will be speaking to you about understanding the difference Alzheimer's disease versus frontotemporal dementia. And I can see there are already some questions coming up about the difference between frontotemporal dementia and vascular dementia. We will be taking questions later on. We just ask that you put them in the chat, and then we will be going through as many questions as we can. And it's so nice to see people from all over the place, from Delray Beach, Wilno, Carleton Place, Ottawa, and I believe there's somebody joining us from down east as well. The Dementia Society of Ottawa and Renfrew County acknowledges the privilege to be operating on the unceded territory, traditional territory of the Algonquin Anishinaabe. The people of the Anishinaabe, my apologies, the people of the Anishinaabe Algonquin Nation have lived on this territory for millennia. Their culture and presence have nurtured and continue to nurture this land. The Dementia Society honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. My name is Monique Doolittle-Romas. I hope that I've had the pleasure of meeting some of you. I am the CEO of the Dementia Society of Ottawa, Renfrew County. Let me tell you a little bit about the Dementia Society. Our team provides compassionate support, tailored coaching, and practical education for everyone impacted by dementia, while we build a dementia-inclusive community. For more than 44 years, we have helped many thousands of caregivers and loved ones to navigate dementia and dementia care, thanks to the generous support of donors and our community, and of course, Ontario Health. As the dementia numbers increase, more programs are required, as well as funding to deliver them. Thank you for your support. Should you be so inclined, you can go to dementiahelp.ca, donate. This month is Alzheimer's Awareness Month, and this is one of the reasons we are hosting this webinar with Dr. Frank this evening. We at the Dementia Society are deeply committed to raising awareness about Alzheimer's. By understanding the difference between Alzheimer's and other types of dementia, we can promote early recognition, foster greater empathy, and advocate for better care and treatment options. Awareness is essential for breaking stigma, supporting caregivers, and advancing vital research. And our theme for this year's campaign is Open the Door to Dementia. Let's reduce stigma in all its forms. A little bit about our process today. We want to advise you that the webinar is being live cast and recorded for future on-demand viewing for participants who cannot join us this evening. Everyone but our speakers and event coordinators are muted today. We encourage you to please pose questions in the chat function or the Q&A box, and we will do our best to answer them at the end of the webinar. For your privacy, please do not share personal health information. And remember, this information is shared in this webinar as an information resource only, and it is not to be used or relied upon for any diagnostic or treatment purposes. This information should not be used as a substitute for professional medical advice, diagnosis, or treatment. It is now my pleasure to introduce a good friend to the Dementia Society and to our community, Dr. Andrew Frank, MD, Bachelor of Science Honors, F.R.C.P. He is a cognitive and behavioral neurologist at B.Sc.H Health, and he's going to speak to us today, understanding the difference Alzheimer's disease versus frontotemporal dementia. Thank you for your time today, Dr. Frank. Thank you for joining us. We are looking forward to your presentation.
Thank you, Monique, and to Herman for having me this evening. We at B.Sc.H Health Memory Clinic, where I work, are very thankful for our connection with the Dementia Society, because we have the privilege of seeing many families who are unfortunately affected by dementia, and there is such a great need for support. And our clinic can't always provide all the support that's needed. And the Dementia Society has been an amazing partner in providing assistance to families as they navigate the healthcare system in the face of a very challenging illness, which is dementia caused by Alzheimer's disease. Tonight's discussion will be about Alzheimer's disease, but also another condition, as you can see here, known as frontotemporal dementia. Have you heard of this term before? It's not as commonly known as Alzheimer's disease, but yet it exists and can be very striking and destructive to individuals. As much as Alzheimer's and dementia can be, frontotemporal dementia may be even more acute and may occur at an even younger age than dementia due to Alzheimer's disease. So tonight, we're going to discuss some of the similarities and differences between Alzheimer's disease and frontotemporal dementia, and then, of course, take your questions at the end. First, we must discuss perhaps one of the most confusing topics, which is what is the meaning of the word dementia, and is it different from the word Alzheimer's disease? And it is. Dementia is a medical term which refers to memory or thinking loss, which is enough to take away independence. So that is a definition, a textbook definition, which must be met to use the term dementia. Cognitive change or memory loss in which independence is lost. There can be a mild dementia in which only some independence is lost with complicated activities like pills and medications. There can be a moderate dementia in which independence is lost to a greater degree, even involving basic daily chores like dressing and hygiene. And then severe dementia in which independence is lost for every single daily activity. And in this spectrum, you can see the great tragedy that is dementia, in that individuals who were once so vibrant have all of their independence taken away through these stages, ruthlessly, due to a condition like Alzheimer's disease, which brings us to our next slide. There are four main causes of dementia. Alzheimer's disease is the most common cause of dementia, which is why Alzheimer's and dementia are often used synonymously, but they're not the same. Dementia is, as I've described, a cognitive loss and loss of independence. And Alzheimer's is the cause of the dementia. How could that be? As we'll discuss tonight, Alzheimer's disease is a buildup of toxic proteins in the brain. Those proteins start normal, but as they build up, they start to damage the brain, destroy the brain. And as the brain is destroyed, the functioning or independence becomes lost. So Alzheimer's disease and the proteins of Alzheimer's disease in the brain are the cause, and dementia is the result, progressing in those stages that I described. Now, there are other causes of dementia, and that's the key point here. There is vascular dementia. Someone may have been asking about that. Vascular dementia is a loss of thinking and independence due to a stroke. A stroke is where the blood is blocked from the brain, the oxygen is blocked, so the brain is suddenly damaged in a stroke. And if that stroke causes that cognitive loss and independence loss, we call that vascular dementia, dementia caused by stroke. There is dementia with Lewy bodies, in which there is dementia caused by Lewy bodies, which are tiny protein buildups in the brain that can be seen under the microscope. How is that different than Alzheimer's disease? Because Alzheimer's is also caused by proteins. Well, dementia with Lewy body is caused by a different protein. We have the Lewy body protein causing dementia with Lewy bodies, and we have the Alzheimer's protein causing Alzheimer's disease dementia. So interestingly, both conditions are caused by buildup of proteins, but the proteins are different. And with each protein comes a different disease. And if we can go back one. Lastly, the fourth major cause of dementia is frontotemporal dementia, FTD, which we're going to talk about tonight. And once again, and you're going to see a theme here, this condition is also caused by proteins that build up in the brain. But once again, the frontotemporal dementia is a different protein from the Lewy body protein, from the Alzheimer's protein. With each different protein, we have a different condition. But each of them has a protein that's building up that is toxic or damaging to the brain, causing the brain cell loss and the emergence of dementia, which is the memory loss and the loss of independence. The interesting theme is that all of these are caused by proteins that build up. So this brings up a new class of illness called the proteinopathies, meaning abnormal buildup of proteins. And in some ways, not exactly, it's like cancer. Cancer is a buildup of cells in the body, abnormal cells that start to invade and destroy the body. Here, it's not a buildup of cells, but a buildup of different proteins, each one a different protein. Now, please understand, it's very important for us to eat proteins, of course, through all of the sources that we know, meat and fish, but also plant matter too, has protein. Very important to consume protein because we need that to build our bodies, our muscles, and our brain. But in some individuals, some of the protein pathways go awry, and a critical protein, which starts normal, start to build up. And depending on which protein builds up, that determines which kind of dementia. The Alzheimer's protein causes Alzheimer's, frontotemporal protein causes frontotemporal dementia, and the Lewy body protein causes dementia with Lewy bodies. Next slide. Here is what the Alzheimer protein looks like under the microscope. Someone has passed away with Alzheimer's disease dementia, and under the microscope, their brain shows these globs, which you can see here. And these globs, which were first identified by Dr. Alzheimer, where the name comes from, back in 1906, under his new microscope, he could see these for the first time. And here is the Alzheimer's protein, also called amyloid. There's a second type of protein. We can go to the next slide. There's a second protein that Dr. Alzheimer identified as well that started to build up inside brain cells. The amyloid, or plaques, build up outside of the cells, which we just saw. And inside cells, we have tangles caused by a second protein called tau. So in fact, the Alzheimer's disease proteins are two. There are two different proteins, both of which build up to define Alzheimer's. The amyloid outside the brain cells called plaques, and the tau protein inside the brain cells causing tangles. And together, these proteins are toxic. You can see in this slide how the plaque shown in green, the amyloid plaque, is building up outside of the brain cell, which is black now as it's filled with tau, the red arrow. The plaques and tangles of Alzheimer's disease are choking the brain cell. And as this occurs across the brain, which has billions of brain cells, enough brain cells are destroyed microscopically, enough to cause the symptoms of Alzheimer's disease. That is memory loss and eventual loss of independence, which is dementia. Dementia due to the proteins of Alzheimer's disease. When we look at someone developing Alzheimer's disease under an MRI, a picture of the brain, you can see that we see a difference. On the left, someone normal has a robust or plump brain, as you can see. But on the right, you can see how the areas of the brain, the folds of the brain, are becoming widened. So the brain is shrinking. And that is because even though there are proteins building up, as we just saw, the brain cells are being killed. And so as the brain cells die, the brain itself gets smaller. And as I mentioned, the symptoms start to come out. The hippocampus, which is shown on the side of the sides of the brain, we're sort of looking at the brain face on in these pictures. The sides of the brain, the hippocampus, one on each side, are getting smaller, as you can see, as the brain cells are destroyed. And it's the hippocampus that actually creates a new memory. So in fact, if you're remembering anything from right this moment as I'm speaking, if there's something that's resonating with you and you're going to remember it for later, it's the hippocampus in your brain that is creating the circuitry that you can call upon later to remember what I am saying. There is a physical reality in your brain that maps to the memory of what I'm saying right now. And it's in the hippocampus. And if the hippocampus is destroyed by the proteins of Alzheimer's, it means there can be no new memories. And that's why individuals with Alzheimer's disease, when presented with some information or details or an event, may not remember that information or event even 10, 20 minutes later. And those of you who have experienced this yourself or in your family know that there's that short-term memory loss in Alzheimer's that is directly the result of the proteins destroying the hippocampus. Indeed, that is a description of the symptoms of Alzheimer's. Again, many of you have familiarity with this. A gradual development as those proteins build up in short-term memory loss. So if one is in conversation and makes a comment or asks a question, and if someone else in the conversation answers that question, it may be that in 5 or 10 minutes, the question may be asked again without recollection that it had been asked and answered earlier. The question may be answered a second time, and then after 5 or 10 minutes, it may be asked a third time and then a fourth time, repeating again and again because of the loss of short-term memory, because of the loss of the hippocampus, due to the buildup of amyloid and tau proteins in that area. This is a memory loss that people may not even notice in themselves because they're forgetting that they're forgetting. It sounds so strange, but it's real that someone may not remember that they forgot and therefore are not aware that it has happened. But others have noticed it in them and become concerned. So one of the rules of thumb is that if you are worried about your own memory, but others are not worried about you, that's okay. That's not too dangerous. But if the opposite is true, as I described here, if you're not worried about your memory, but others are worried about you, that's more concerning because you might be forgetting that you're forgetting and there may be a real problem. And the onset of all of this, as you know, tends to take place as we get older, usually after age 65. And usually develops gradually as the proteins build up gradually and worsens significantly over 10 years, moving through those dementia stages that I described earlier, the mild dementia, where there's maybe just a little loss of independence for complicated tasks, like cooking meals or taking medication, then progressing over that 10 years to moderate dementia, where someone loses the ability to remember how to get dressed, how to bathe, and eventually, tragically, the severe dementia where help is needed with everything, which is that great devastation of Alzheimer's. We have some medications that we use today that we've had, in fact, for over 20 years. Medicines like Aricept and Exelon, the cholinesterase inhibitors, these medicines increase the acetylcholine neurotransmitter in the brain. What's a neurotransmitter? It's a way that the billions of brain cells communicate with each other in vast circuits that span across the brain, basically controlling and providing all of the brain functions that we take for granted every day, like our memories and our language and our spatial abilities of navigation and our executive function, which is problem solving and understanding our world as in a very complicated way. And all of that is brought about by neurotransmitters, and cholinesterase inhibitors increase the acetylcholine neurotransmitter and allows the brain to cope with what is an onslaught of increasing proteins, amyloid and tau in the brain, which are choking the brain cells. Another class of medication is the NMDA antagonist memantine, which doesn't increase acetylcholine in this case. It tends to modulate a calcium channel in the brain, which is another way that brain cells try to remain healthy. This particular medication tries to keep the health of brain cells despite those proteins. But all of these medications are not a cure. The proteins can continue to build up. And so while these medications may improve symptoms slightly, there is eventual deterioration and because the proteins continue to accumulate. Shifting gears to frontotemporal dementia. As I mentioned, another of the four major causes of dementia, Alzheimer's disease being one, frontotemporal dementia, dementia with Lewy bodies, and vascular dementia, dementia caused by stroke. Frontotemporal dementia is caused by a different protein profile than Alzheimer's. We mentioned that in Alzheimer's, there's amyloid plaques and tau tangles. Interestingly, many cases of frontotemporal dementia, which we'll describe its presentation in a moment, only has tau protein. There is no amyloid plaque whatsoever. There is only tau tangles in the brain cells. That's interesting. And that is sufficient to destroy the brain cells without the amyloid. Also, and this is the second type of frontotemporal dementia, there is no amyloid and there's no tau. Neither of those are present. Instead, there is a protein called TDP43. It's a unique protein that appears to assist DNA, which is our genetic code, in creating proteins to rebuild the brain. So as you can see, frontotemporal dementia has been categorized separately from Alzheimer's because it has a separate protein profile, either tau on its own, but in fact, in the majority of frontotemporal dementia, there's no amyloid or tau. There is only accumulations of TDP43 protein in the brain. That is a very different protein than Alzheimer's. And so frontotemporal dementia is given its own name. But also, it has a different way of presenting. Next slide. While the Alzheimer's protein, as we just saw, tends to target the hippocampus on each side of the brain, which creates the short-term memory, causing the shrinkage of the brain, especially on the sides. Frontotemporal dementia, as you can see in the name, affects the front part of the brain quite significantly, much more than Alzheimer's. And the temporal lobe, which is the side of the brain, but not so much the hippocampus. The hippocampus is actually in the temporal or side part of the brain. That's true. But in this condition, the front part of the brain is affected the most, and the temporal or side parts not affecting the hippocampus. So again, for two reasons, this condition has been given a new name, frontotemporal dementia because A, there's a different protein profile, including TDP43, as well as a different area of the brain that's affected, mostly the front and the sides, not affecting the hippocampus. That's interesting because that, again, may mean that the symptoms are different because different parts of the brain control different functions. And here it is. As the front part of the brain, and you saw in that last MRI, the front part of the brain was becoming smaller. When the front part of the brain is affected, we get personality changes. Because in fact, the front part of the brain helps control our executive functioning, which is our problem solving, which is a very central part of being human. We take it for granted every day, but we use our organization and problem solving skills all day long to navigate our world. When it's affected, when the frontal lobe is affected, executive function can be significantly affected, like problem solving. But personality, the way that we are uniquely people in the world and recognizable to others, our personality is also controlled by the front part of the brain, the part of the brain that's sort of right underneath our forehead, if you will. And in frontotemporal dementia, remember Alzheimer's, short-term memory loss was the #1 symptom. Not here. In frontotemporal dementia, the first symptom is often a personality change, becoming either very flat, or we call it apathetic, meaning no emotional response, no highs or lows, no happiness, joy, no sadness, despair, no anger or anxiety, just flat. Developing over 1 or 2 years. Just like in Alzheimer's, where the short-term memory loss develops over 1 or 2 years, here we have over 1 or 2 years a flat personality change, which can be shocking to family members or other loved ones who notice this. And once again, the individual themselves may not notice it in themselves, just like with Alzheimer's, but others notice a striking personality change. And it can go the other way too, a childish personality. Instead of becoming flat, it becomes the opposite. It becomes turbulent and with wide swings of outrageous, inappropriate joy or laughter, and depths of despair triggered by minimal reasoning. So either very flat or wild fluctuations in personality, all of which is noticed strikingly by loved ones when an individual does not even notice it in themselves. What a strange presentation that is very different than the Alzheimer's presentation of short-term memory loss. To make matters even more complicated, frontotemporal dementia, if it affects the front part of the brain mostly, has personality changes. But what if it affects that temporal or side part of the brain, but not the hippocampus? The symptoms can be different still. It can be a gradual development of language loss because language is housed in the temporal lobes, not the hippocampus, but the side parts of the brain. And if the TDP43 protein of frontotemporal dementia affects the temporal lobes most, then over 1 to 2 years, and this is also quite tragic, someone will gradually lose the ability to speak. They will become mute. And you can imagine how terrible that would be. To gradually lose the ability to create words, which again, we take for granted, but not when we start to lose it. And we lose the ability to understand words. So not just the output of words, but the input of words from others and our comprehension. And as you can imagine, reading and writing, which are correlates of spoken language, the written language, also affected right alongside either the difficulty to write, produce, or to read, which is comprehension. And here may be one of the most striking aspects of frontotemporal dementia as well. The onset is usually under age 65. The onset of Alzheimer's disease dementia is usually over age 65. Frontotemporal dementia is a young onset dementia. It affects usually people under 65, under 60, and sometimes under 50, often developing in individuals who are still working, individuals who may yet have young families, and again, over 1 to 2 years, these devastating symptoms regarding personality change or language loss in what might be called someone the prime of their lives, potentially. And it tends to progress faster than Alzheimer's disease. Alzheimer's disease, as we described, over 10 years on average, from mild to moderate to severe. Here, it is possible to move through those 3 stages even within 5 years. Sometimes longer, but it starts younger and it progresses faster. As devastating as Alzheimer's dementia is, and again, many of you know that on this call, the devastation of frontotemporal dementia is shocking, affecting someone so young and so quickly in such a way. And that is why we're talking about it tonight. Sadly, there are no approved treatments for this condition. It's less common than Alzheimer's disease dementia. That's why not everyone's heard of it. And research into this condition is behind the research into Alzheimer's disease dementia. So there is no approved treatment. That is quite terrible. We do use, empirically, antidepressant therapy for those who understandably start to show mood changes or wild mood fluctuations, as I described, or that emotional flatness that I described, may respond to antidepressant therapy, like Cipralex or some older ones, like sertraline or paroxetine. Antipsychotic therapies, like risperidone or olanzapine or quetiapine. These medicines can calm someone if their emotions get out of control and create anxiety, but also agitation and aggression. All symptoms, which can occur in Alzheimer's disease dementia, but can certainly occur in frontotemporal dementia if that personality becomes released in that way. These treatments have some benefit, but again, can only cause temporary slowing of symptoms as the protein, such as TDP43 of frontotemporal dementia, accumulates. Risk factors for both Alzheimer's disease dementia and frontotemporal dementia: family history. Please understand, though, that if family has these conditions in them, that does not mean that everyone in the family will develop these conditions. It does increase the risk somewhat by 5, 10, perhaps 15%, depending on how many people in the family have been affected. But please understand that it does not mean that everyone in the family will be affected for both conditions. And stroke previously, or any brain injury, can increase the risk of Alzheimer's disease dementia in older individuals and frontotemporal dementia in younger individuals. Again, frontotemporal dementia overall is less common than Alzheimer's disease. And previous head injury, once again, can increase risk of both of these conditions. And that has taken place, of course, in individuals playing football, but quite significantly here in Canada in hockey, which is why there continues to be that push for safe helmets, concussion monitoring, removal from play, because multiple concussions can increase risk for either of these dementias. We know that anything that helps prevent heart attack and stroke can also prevent dementia. And I'm talking about vascular risk factors like high blood pressure, cholesterol, diabetes, stopping smoking, loss of excess weight, and maintaining an active lifestyle with physical activity and mental activity like hobbies, physical activities like walking, social involvement, and of course, balanced diet, all highly recommended to prevent heart attack and stroke for sure, but also Alzheimer's dementia in those who are older and frontotemporal dementia in those that are younger. I will mention a special case in which there are rare families in the world that develop a very high level of dementia. These are known as familial dementia and can occur with familial Alzheimer's disease, often again with a very young onset, which is different than the usual presentation. And there are many families in the world that have familial frontotemporal dementia. These families indeed have a special mutation, which is a change in the DNA that will in fact cause the dementia in them. And so most cases of these dementias are not this genetic mutation, which is why I don't want everyone in the family to think that they are inevitably going to be affected by these conditions. But if a family has multiple individuals affected by either Alzheimer's or frontotemporal dementia, multiple family members over multiple generations, that scenario does prompt what we call genetic analysis to check for a mutation. And that can be done even with a blood test. And in that special case, if a blood test shows a mutation that causes Alzheimer's or frontotemporal dementia, it means that that individual will get Alzheimer's and dementia because they have inherited a special mutation that places them at the highest risk. In fact, they will get the condition. And what makes the genetic, those families who have been unfortunately afflicted in this way, is that each of these genes that are affected give a clue as to what might cause the buildup of these proteins in the first place. Because you may have been asking, why do these proteins build up at all? Why do the amyloid and tau proteins build up? Why did the TDP43 protein build up in FTD? And we're not entirely sure. But for those families who unfortunately have been afflicted by this very aggressive and prevalent in multiple family members over multiple generations, trying to analyze which genes have been affected by these mutations do give us that research that we mentioned earlier to try to figure out what is actually causing these terrible conditions and could that one day lead to a treatment. Coming back to our earlier discussion on how we can try to prevent these terrible conditions, we do look at things like sleep. We look at mood and vision and hearing. We do at our clinic a lot of sleep apnea tests, like sleep studies to check for sleep apnea because that can decrease our oxygen levels and that can increase risk of stroke and dementia of both types. Mood, depression and anxiety can be symptoms of Alzheimer's and symptoms of frontotemporal dementia, but having depression and anxiety beforehand can accentuate memory symptoms if they come on later. And lastly, vision and hearing. Anything which diminishes stimulation of the brain or decreases activity of the brain, which is why we were recommending a healthy lifestyle. We want to stimulate the brain. And so optimization of vision and hearing can provide yet more stimulation to the brain, keeping it healthy over time. How do we diagnose Alzheimer's and frontotemporal dementia? We do memory testing with paper and pencil tests. Some of you may be familiar with these things, where we ask someone to try to remember 5 words, and we come back to those words later. When it comes to testing executive function or frontal lobe testing in frontotemporal dementia, we have people solve problems like connecting the dots between numbers and letters switching between 1A, 2B, 3C, etc., switching between numbers and letters is a kind of problem solving, and that actually tests the frontal part of the brain, which can be affected in FTD. For the language variant of FTD, where the language is affected, we do language testing, such as providing pictures of objects. It seems so simplistic. We provide pictures of objects, and people have to name what they see. And yet, if there's brain damage in those temporal lobes in FTD, people lose the ability to name objects. And again, as I've seen it over the years, in clinic, it can be so devastating. Just like the personality change and just like the short-term memory loss in Alzheimer's. And we do the CAT scan or MRI to check for shrinkage of the brain in the hippocampus for Alzheimer's and in the frontal and temporal areas of the brain for FTD. We do blood tests to try to rule out vitamin deficiencies, which can mimic these conditions like B12 deficiency and thyroid conditions. All of these conditions can mimic Alzheimer's and FTD, so we want to check for that. And then we put it all together with a physician like myself trying to determine, is someone's symptoms indicative of Alzheimer's or FTD, frontotemporal dementia, or Lewy body disease, vascular dementia, or are someone's symptoms just due to the normal aging effect? Because all of us know as we're getting older, memory slows down a bit. So a lot of my work, in fact, is determining if someone has a memory symptom, do they have Alzheimer's, in fact, or do they have normal aging? And so my job is dedicated to that. And I'm happy to say that about a third of the people that I see, I'm able to give good news that there is no Alzheimer's or FTD present. To further investigate, a new technology has arisen known as the PET scan. Different than MRI and CAT scans, which show the structure of the brain. The PET scan can actually be set up to check for metabolism, that means energy usage. But in this case, known as the amyloid PET scan, this is a scan for the amyloid protein itself. So this is a way to check for that amyloid or Alzheimer's protein in someone who's very much alive. Remember, Dr. Alzheimer's himself waited for the person to pass away and did an autopsy to look at that brain structure under the microscope to see if the protein was there after they had died. Now, through amyloid PET technology, with a special injected dye, DYE, you can see if there's amyloid in the brain of someone who's very much alive. And you can see on the left, the scan is lighting up just a little bit. There's actually no amyloid there. In the middle, mild cognitive impairment is like an early stage of Alzheimer's, and there is some lighting up of the protein there. And look on the right, Alzheimer's disease, amyloid protein is significant in this scan, showing that the amyloid protein, the plaques, are diffusely distributed in the brain. And there it is, the determination of the amyloid in someone who's very much alive. And look, with a slightly different dye or tracer known for tau, we call this the tau PET scan, injected into the vein. Again, these dyes go into the brain and stick to the target. So if it's amyloid PET scan, it's sticking to amyloid. This particular tracer is sticking to the tau protein and creating a spinning image here of the brain that is showing buildup of the tau protein in the temporal lobes. This may be the appearance of frontotemporal dementia, of the tau building up in the temporal and slightly the frontal part of the brain. I know this is spinning, so it might be hard to see, but there's a side view right there. Both the frontal and temporal areas of the brain have tau accumulation. This may represent frontotemporal dementia, especially if there's no amyloid present. You might be asking, do we have a TDP43? That's that other protein I talked about that causes frontotemporal dementia, and we do not yet have the TDP43 PET scan to check for that protein. But one day we will, and we will be using this technology to try to determine which protein, if any, an individual is accumulating. This is very similar to how we diagnose cancer today. We determine if there's a growth. We do biopsies to determine what kind of cell is growing. In the future of this field, we will be doing scans, sometimes lumbar punctures, which is a spinal tap, and also blood tests. We're going to be doing blood tests to try to check which proteins people are accumulating to know, do they have amyloid? Do they have tau? Do they have TDP43? Because like in cancer, we want to develop a tailored diagnosis based on the exact protein which is present, which may one day allow us to tailor the treatment. And that leads us to the last aspect of our talk tonight. Is there any way to get rid of these proteins that we've been talking about tonight? Can we get rid of amyloid from the brain if it's so toxic? Can we get rid of tau? Can we get rid of TDP43 in frontotemporal dementia? Well, so far of those three, we have one that has shown promise over the past 2 to 3 years, known as anti-amyloid antibody therapy. Antibodies are themselves tiny proteins which usually stick to viruses and bacteria to allow us to fight off infections like COVID-19. Antibodies. In this case, antibodies have been developed not against a virus, but against a protein, the amyloid protein, an anti-amyloid antibody, which can be administered intravenously. They then enter the body and cross into the brain, stick to amyloid, the toxic protein, and allow the immune system to get rid of it. It was hoped that this type of approach would represent the cure for Alzheimer's. Now, that didn't happen exactly, but we did get some promising results. In 2023, as published here in the New England Journal of Medicine, one of the two anti-amyloid antibody treatments known as lecanemab, very challenging names, but lecanemab was published, which showed, next slide, that over 18 months on the x-axis, those who received lecanemab, remember in these trials, half the people receive the active drug intravenously and half the people get a placebo intravenously, and neither one knows what they're getting. Even the doctors don't know. Double-blind, placebo-controlled study of lecanemab. Over 18 months, the amyloid PET scan that I just showed, that there was a massive removal of amyloid from the brain, just as intended by as intended in the development of lecanemab. Now, the amyloid was removed. So how did that help the memory? Over 18 months, those who were treated with lecanemab appeared, as you can see here, to decline less, or they declined more slowly than those on placebo. Both groups did get worse in terms of their memory over 18 months, but those on the lecanemab got worse at a slower rate. The subgroup analysis of this demonstration show that those who received the treatment in the earliest stages, when the memory loss was mildest, had the greatest benefit. And it is believed that while this treatment is not a cure, as you can see, it removed the amyloid but was not a cure. It did not totally stop the worsening. It did not reverse the worsening. It slowed the worsening. And so it is believed that with early detection and diagnosis, those who were treated earliest got the greatest benefit, and that if treatment is started early, that individuals may have slowing of their condition, and they may be able to achieve a longer, healthier life without the ravages of the dementia, the memory loss, compared to those who are not treated. Therefore, lecanemab has been approved in the United States and in Great Britain, in Japan, and other countries around the world. It is believed that Europe will be approving this quite soon. We'll approve this quite soon. And it is hoped that Canada will approve this particular medication, hopefully over the next 3 months. And we hope to start using this treatment at our clinic here in Ottawa in those who are developing Alzheimer's disease at the mildest stages. Next slide. This intravenous medicine does have potential side effects, though. As you can see, there can be an increased rate compared to placebo of headache and falls by a small amount. But the main side effects to focus on are infusion-related reactions, which is kind of like an allergic reaction. This is an intravenous medicine, and some people get a bit of an allergic reaction when it's infused into the vein. So as we start to use this treatment, we're going to be administering it at specialized clinics, which are dedicated to giving infusions, intravenous infusions. These clinics are used for chemotherapies for cancer. We hope to use similar clinics to give lecanemab and watch for any allergic reactions. Also, a major important adverse or side effect of lecanemab is it may cause ARIA, A-R-I-A, E and ARIA-H. ARIA stands for amyloid-related imaging abnormalities, and E and H stands for edema and hemorrhage. What I'm referring to is that this treatment can induce swelling in the brain and hemorrhage or bleeding in the brain. Why would that be? It's believed that as the lecanemab sticks to the amyloid and the body starts to clear it, there can be swelling and there can be bleeding. Most of the time, there are no symptoms associated with this. But sometimes, and if we can go to the next slide. Actually, let's go back. Sometimes ARIA-E and ARIA-H, and I'll show a diagram of this in a moment, can cause stroke-like symptoms. And that is a serious side effect. So anyone considering this treatment when approved will be carefully counseled on watching for any headaches or dizziness or any stroke-like symptoms like numbness or tingling or weakness on one side of the body over the other, double vision, because that could potentially be a side effect on this treatment, which we hope will help by removing amyloid, but may cause side effects. Later in 2023, a second anti-amyloid antibody, this one pronounced donanemab, was also published. Next slide. And here, once again, over 18 months, the placebo group over time declined, and the treated group in green declined over time, this time showing a 35% slowing. Lecanemab showed 27% slowing of the disease. Again, not a cure. Donanemab showing 35% slowing. Some individual would consider that an important difference, possibly even worth any chance at those side effects like swelling or bleeding in the brain. However, this chance may not be sufficient to justify side effects as I've described. This will be a discussion we will be having with individuals and their families if they wish to consider this kind of medication, given its potential benefit of 27 to 35%, but its chance of side effects as well, including swelling and bleeding in the brain. Next slide. In fact, over time, this graph shows the rate at which the dementia worsened from its mildest stages. And we discussed this earlier, dementia in the mild stage, which is where there's only some difficulty with independence, to the moderate stage, where there's even more assistance required with things like getting dressed or bathed. This graph is showing the rate at which people were transitioning from the mild stage of dementia to the moderate stage. As you can see in the treated group, the green, the rate of conversion to the more moderate stage was slower over the 18 months. So the higher the curve goes, that's the conversion to the moderate stage. And you can see that the gray group, untreated was converting at a faster rate than the green group, which was treated. Again, all of this was treated in a placebo-controlled. Both groups got the intravenous, but neither side knew if they were getting the actual drug or the placebo. And there was a difference. In this, I see encouragement because this is progress in our quest, if you will, to find treatments for these devastating conditions. Again, it's not a cure. Perhaps it's only 35% slowing of the disease, but in this I see progress. And again, the side effects, like the infusion-related reaction, you can see placebo versus donanemab. And you can show the arrow there, the infusion-related reaction. Just 0.5% placebo had 8.7% in the donanemab group, which was much higher. So we have to watch for those allergic reactions. And then if you can show higher up the ARIA, amyloid-related imaging abnormalities, E and H, the edema and the hemorrhage, you can see the difference. The placebo group was just 2% in the placebo group of the swelling, but up to 24% of swelling in those who were treated. That's a big difference. And if you go to the next slide, this is an important one. These 24% are those out of 100, 24 out of 100. You can see they're colored in black, the 24 people. But only 6, and this is an important statistic, 6% had symptoms related. So while 24% had slowing on this treatment, 24% had the swelling on this treatment, only 6% had symptoms related to that. Symptoms like headache and dizziness or stroke-like symptoms. And I would say 1%, based on the data that's been shown, 1% had a symptom that did not go away. So the majority of individuals who were treated, who had swelling, did not have symptoms, but 6% of the group did have symptoms, and about 1% had persistent, non-resolving symptoms. And that is a risk that some people may not wish to take for a 35% slowing of disease. So this is not a cure. It is not that home run treatment that we wish it was. But I see in it progress in that it's our first treatment that's directed against one of these proteins that's showing some slowing of disease progression. And it appears that benefit is greatest in those who are treated in the earliest stages. So we recommend early detection and early treatment. But you may be asking, if this is a treatment against the amyloid protein, do we have a similar antibody against the tau protein in Alzheimer's and frontotemporal dementia? Do we have a similar antibody against the TDP43 protein? And the answer is we do, and they are currently in clinical trials. So there is hope that there will be progress in testing antibody treatments against other proteins as well. And that one day, we pray, there will be a way to test for which proteins someone is accumulating, just like in cancer, where we test what type of cell someone is accumulated. And then we would target the treatment to which protein they are accumulating. If it's against amyloid or tau or TDP43, we would tailor the treatment to whichever protein they are accumulating in hopes of one day treating these devastating conditions. And so to conclude, dementia is a memory or thinking change that takes away independence. First, the mild dementia, where complicated activities are lost, and then moderate dementia, where simple activities are lost. Even basic daily activities like getting dressed or bathed, and tragically severe dementia, where all function is lost. Alzheimer's disease is the most common cause of dementia, where it's amyloid and tau proteins building up, causing gradual short-term memory loss, often after age 65. And as I've just described, the new anti-amyloid antibody treatments may become approved in Canada, hopefully over the next 3 to 6 months. And we hope to use this treatment in those in the mildest stages of the condition in whom we clearly discuss the risk of that swelling or bleeding in the brain, which can cause symptoms in some cases, occasionally and rarely persistent. And then frontotemporal dementia, another less common cause of dementia, in which tau alone or TDP43 builds up into the brain, creating toxicity, leading to a gradual personality flattening or personality release, becoming very childish or perhaps wildly fluctuating, or gradual language loss, our ability to speak or understand words, reading and writing over a faster period of time, perhaps over just 5 to 7 years, as opposed to 10 to 15 years in Alzheimer's, a more aggressive form of dementia, affecting personality and language critically, often before the age 65, thereby being a young onset dementia. As tragic as dementia due to Alzheimer's is, it's possible that that young and aggressive onset in frontotemporal dementia may be even more shocking. And sadly, there is no approved treatment yet. But is it possible that this anti-protein antibody approach may yield positive results in frontotemporal dementia? I truly hope so. And results of such trials will be published over the next 5 years. And I look forward to those results. And I look forward to the future, where I hope that new treatments for both of these conditions will become available. Thank you so much for your attention.
Thank you so much, Dr. Frank. You have a gift for presenting that we can absorb the information. You have a gift for explaining it in a very calm fashion, which it can be intimidating a little bit and a little bit challenging
Thank
for
you, Margaret.
caregivers and people living with dementia. If you have time, could we pose a few questions for you,
Yes,
Dr.
of course.
Frank?
Of course.
The first one would be, can the type of dementia be simply identified by identifying the protein that's built up, i.e. using a diagnostic test or a microscope examination?
Under the microscope, of course, that would be at autopsy. That's after someone has passed away. We often do not do brain biopsies while someone's living. To take a sample of the brain under the microscope, that is usually not performed. We are doing those PET scans that I described to check for the amyloid protein, the tau protein, and we are doing lumbar punctures, spinal taps, which can also check for those proteins, and we can use blood tests. Those blood tests are showing significantly encouraging results, which show validity that correlates to the amyloid PET scan and lumbar puncture. So if we can do a blood test that gives us the same information that would otherwise require that complicated scan, we intend to use blood tests in the future. And then to answer the question, if we identify the correct protein in any of these ways, that does create the diagnosis. Yes, these diagnoses are truly defined based on their proteins. They're also defined on their symptoms, of course, but in a very profound way, it's the protein that is their cause. And so it is the protein identification that is their true definition.
Thank you so much. Is it still a rule of thumb that someone with Alzheimer's disease typically will die within 5 years of diagnosis?
No, that is much too rapid in my experience. Perhaps the average of the condition is 10 years, not 5. However, I have seen many individuals live much longer than 10 years. Perhaps that's due to some of those treatments we have available today, like Aricept. Perhaps it's due to healthy lifestyle, which, as I described, is really important. And of course, perhaps it's due to the love and caring that their family and loved one provides them. That can also help someone live a full life, even with dementia, and much longer than 5 or 10 years.
Caregivers truly are inspiring and so important to the well-being of their loved one and making sure they live their best lives.
Mhm.
Would you recommend any baseline testing, Dr. Frank?
That has been debated, meaning should everyone in the population have a memory test when they turn 50 or 60 or 70? And the answer that we've sort of decided on is no, that is not required. Memory testing is best used when there are symptoms that someone identifies in themselves or in a loved one. So if someone has symptoms that they notice in themselves, that may not be dangerous. Again, when someone notices symptoms in themselves, that's usually less concerning. But if someone does notice symptoms in themselves and or a loved one notices in them, that is the right time to do a baseline at that moment. Having everyone in the population do a memory test at age 55 or 60 is likely not the best use of resources. Therefore, having everyone do a baseline is not required, but if there's a hint of symptoms, that's the time to trigger one.
Thank you. If a loved one is seeing memory loss, personality changes, and their patient isn't, or the loved one is in denial, what course of action can or should they take?
Hmm. It is very challenging because, as I described, Alzheimer's dementia can cause a lack of insight into one's forgetfulness because one may forget that they're forgetting. And classically, frontotemporal dementia too, while less common, that can very commonly, classically create a lack of insight into one's own problems. And that can lead to great resistance to getting testing. It's challenging. Again, one more challenge for caregivers to overcome. If there's any way, perhaps even just a visit to a family doctor. Sometimes a family doctor may be someone trusted. If just general checkup, visiting the family physician as a general checkup. And if the family physician could be provided some information, this is not meant to this is not meant to trick or withhold information from a loved one. But if some details could be provided to the family physician just on the side, that a family has identified a concern regarding memory or brain function, then that family physician could just very um, passively recommend a memory test, not to not to surprise someone, not to threaten someone, just as a matter of course, so to speak. In such a non-threatening way, it is possible that a family could arrange testing to take place in a trusted environment. And that would be, and hopefully an individual would not be aggressive or angered. And hopefully there'd be no blame attached to family members. But if gently that the testing could be worked into a general checkup, that might be a helpful strategy to start the process of detection and diagnosis.
As you say, it's a very challenging situation for a caregiver. For the rare dementia posterior cortical atrophy, is there a particular protein different from the tau and amyloid also involved?
Okay. Thank you for that question. There is an entity called, again, this is not well publicized. It is known as posterior cortical atrophy. Posterior cortical atrophy is a variant of Alzheimer's disease, which means, to answer the question, there is amyloid and tau proteins, just as I described. Just as defined, Alzheimer's disease, amyloid and tau proteins. But the difference is, in this particular variant, the amyloid and tau proteins, for some reason that we do not fully understand, the amyloid and tau proteins are building up posteriorly, which means at the back part of the brain. Why is that happening? It's not building up in the hippocampal area like it normally does with the short-term memory loss, building up posteriorly. And the back part of the brain is where vision is calculated and performed by the brain. And so individuals with posterior cortical atrophy develop over 1 to 2 years a gradual inability to recognize objects that they are seeing. I'm not talking about a language loss. It's not that they don't know the word. They know the word, but if you show it to them, it does not look like that anymore. An object like a flower could look like a series of colored lines which are intersecting themselves and don't look like anything. How strange is that? And so if you ask them, what is this? They would not know that it's a flower because it looks like a bunch of jagged lines, which doesn't look like anything. But if you ask them what a flower is, they say, oh, flowers are these beautiful things that grow in the garden. Well, do we have any flowers? There's no change in language, but difficulty with vision. So posterior cortical atrophy is a vision variant of Alzheimer's that are defined by the very same proteins which are building up in the vision centers.
Thank you. Is primary progressive aphasia a precursor to frontotemporal dementia?
Thank you for asking that. Primary progressive aphasia, or PPA, is in fact the language variant of frontotemporal dementia. So PPA fits within frontotemporal dementia. As I mentioned, the frontotemporal dementia can affect the front part of the brain or the temporal part of the brain. The front part of the brain is the personality change. The temporal part of the brain is the language change. And if it's the language change, we have another term called primary progressive aphasia, which in fact is the temporal form of frontotemporal dementia, which again are caused by the proteins tau alone or TDP43.
And one more question. There are so many. I wish we could take all of the questions. We appreciate your time that you're giving us today.
Nope.
Does FTD affect large muscle movements and eye-hand coordination, such as throwing and catching a ball?
The answer is yes. Frontotemporal dementia with its buildup of TDP43 can also affect not brain cells, but cells in the spinal cord. And that creates an overlap with the condition ALS, Lou Gehrig's disease. ALS, Lou Gehrig's disease, is also caused by TDP43 in the spinal cord. That is quite profound, because that means that Lou Gehrig's disease is also caused by a protein buildup in other brain cells, and FTD can overlap with ALS. So it is possible with FTD, not always, but in some individuals with FTD, there can be muscle weakness and twitching and loss of coordination, as can occur in Lou Gehrig's disease, ALS, that can co-occur with frontotemporal dementia. And as devastating as FTD is by itself, if coupled with motor neuron disease, which is ALS, Lou Gehrig's, it becomes even worse.
Thank you so much, Dr. Frank, for taking the time for this presentation and for answering all of these questions. And every time I hear you speak, I learn so much more. So I appreciate your time with us today. Now we need everyone's help, as well as Dr. Frank's. We're asking you to please complete this survey. Did you find the information provided today useful? I would say from all the questions and the reactions, it's going to be a yes. Do you plan to apply any of today's learning? And would you recommend this webinar to a friend? As you know, the webinar will be available on the Dementia Society website. Do you currently or have you previously used the services of the Dementia Society? And how did you hear about today's webinar? What topics would you like to hear more about in future webinars? And there's a few options there for you. And if you selected other, if you can provide us with a few details. We will also follow up with a link to the recorded portion of this webinar, as well as following up with another survey for you to take the time to provide your very essential feedback. Your guidance allows us to develop the appropriate content and find amazing local experts such as Dr. Frank. I encourage you to go to our website, our Dementia Learning Hub, and take the time there. You can learn at your own pace when you have the opportunity. There's all kinds of information from brain health and aging about dementia, how to care for ourselves, as well as right through to the later stages of dementia. And again, we thank you for your support. We thank you for your participation this evening. Thank you, Herman, for organizing this amazing webinar again. And again, Dr. Frank, thank you for spending this time with us and for sharing your expertise and for the care you provide to people living with dementia in our community. Thank you,
Thank you.
everyone, and have a wonderful evening.
Thank you so much, everyone.